All right, everyone, we're going to go ahead and get started. I ask that if you're not speaking, please put yourself on mute as this will be recorded. Shane, if you could go to the next slide for me. So I want to welcome everyone to FMDA's Journal Club this February in 2022. It feels like it's been a very long time, but I know we spoke last month. Today, I'm very excited because we're joined by Dr. Reyes and Dr. Satyavolu. I don't know if I said the name right, but they'll be introducing themselves in a few moments. If we could go ahead and start with just the overview, what we're going to do as far as our agenda, we're going to just run through some hot topics. I'm sure you'll be shocked when you hear about what the hot topics are. And then we're going to do a deep dive into atrial fibrillation and open it up for discussion. If you go to our next slide, just so that, everyone is not shocked, it is still COVID as the hot topic. But, we do have some really encouraging signs and a lot of better news that we've had in the previous months. I think when we last spoke, we were doing a lot of forecasting and we thought we would be seeing a decline in cases. And as we advance to the next slide, you'll see that we have seen a sharp decline over the past few weeks. The 7-day moving average in the US for positivity rates is 11.17%. In Florida, that's dropped down to 8.2%. We're still seeing a larger number of cases and a higher number of deaths than what we saw with the Delta wave, but it does feel like we're moving in a good direction and what we thought we were going to see per that forecasting. The next slide is just another view from of the data where we're looking at cases versus deaths. And as you can see, we're going down for both of those. I believe yesterday we had 49,965 new cases, but we've logged in only 655 deaths. So the numbers are getting a little bit better. And what we're seeing when it comes to variant proportions, I've had a lot of questions about this in the recent weeks. If you advance to the next slide for me, Shane, we're still seeing that the predominant variant is the BA 1.1 for the Omicron. We do see other variants of Omicron, but we're tracking that. We haven't seen a new surge with it. We're just monitoring those cases, and there is a lot of studying being done with the CDC and other institutions across the country trying to predict where we're going next. For now, the biggest question I think that we've been on our mind is, what does this mean and where are we going in the future? And you may have heard the word endemic a lot. I've actually had a great conversation with Dr. Swati Gar in January about being prepared for an endemic and what that looks like for post-acute long-term care. And if we go to the next slide, it's just something that we need to start thinking about. We now have more tools in our toolbox with the vaccinations and the boosters, which we're still lagging behind with boosters. So we need to continue to encourage our staff and our residents and our fellow clinicians to be boosted. But we really do need to make plans and preparations of what does that look like in the future. One thing I will say that I'm very happy about is that it now feels like we're ready as a journal club to move forward and not just focus only on COVID topics. So with that, if you go to the next slide, Shane, just want to say that this month is the American Heart Month, and it is a really good, gives us a great opportunity to introduce our topic that Dr. Reyes sent to us as an idea last month, and I'm really excited for it. So I am going to turn this over to Dr. Reyes and Dr. Satyavolu. Did I say it right yet? No?
Yeah, you got it. You got it close enough.
All right, so I turned it all over to you guys.
I want a quick introduction, Dr. Sanders. Thank you very much again for allowing me to be here in this forum. Obviously, I'm biased to say all the time that if I have to determine value on the professional memberships I have, FMDA is still #1 by far. And I have to, one of the perks of my job is that I have the pleasure and the honor to work with very, very, very smart people like Shannu, who is going to be co-presenting with me today. Also, I want to acknowledge that Dr. Gold, I think I saw him on the list of guests. I think that, if I'm not mistaken, yes, Dr. Goldberg is here, and I just want to acknowledge his presence because Dr. Goldberg was the reason why I became a geriatrician. He was my attendant when I was a PGY2, and he was the one who brought me for the first time to a home visit, and he was, he was the inspiration that served me to decide to pursue this career. So thank you for being here. And also, obviously, Dr. Auslander, my mentor, thank you very much again, and everybody. With that, I pass it along to Shannu, so he's going to start talking. And Shannu, I will just tell me when you want me to pass each slide, okay?
Yeah, thank you very much, Dr. Reyes, and thank you very much, Dr. Sanders, and everybody on the panel. I really appreciate this opportunity to be presenting. As Dr. Reyes mentioned, it's kind of like a chain that we're following. Dr. Reyes has been an excellent mentor for me as well. I really, really, appreciate his giving me this opportunity to actually present in front of an elite panel like all of you guys. So thank you very much.
And just to jump in real quick, sorry to interrupt, Dr. Reyes, do you want to share the slides, or do you want me to continue to do so?
I will share the slides.
Okay, you're willing to go if you just want to go ahead and share your screen.
I will. Actually, no, you do it. Go ahead. I'm sorry, you go ahead.
No worries. All right, whenever you're ready, thanks.
All right, perfect. All right, so without further ado, we can move on to the next slide. All right, no conflict of interest, as noted. All right, so I'll start by saying atrial fibrillation is actually one of the most common arrhythmias and cardiovascular diseases that we typically encounter in the healthcare, with almost 6.1 million people affected in the United States, out of which a big chunk of this number can be attributed to the geriatric population, with almost, as you can see, 10 to 17% of prevalence in patients beyond the age of 80 years or older. What's also interesting is that the population of patients above the age of 65 have what we see doubled from 12% in 2010 to 22% in 2040. And actually, based on the data from Framingham Heart Study, the prevalence of atrial fibrillation actually has increased over threefold in the last 50 years. And it's actually estimated that by 2050, we could expect to see about 16 million patients affected in the US itself. And if I remember correctly, I think it's about expected 14 million in Europe, and it's a whopping 72 million patients in Asia. And so what we do also have to make note in this type of a situation is that the increase in awareness and enhanced detection of atrial fibrillation has improved significantly over the past decade, which has actually been very, very crucial in identifying about more than a third of the AFib population who are actually typically asymptomatic. Oh, are you not able to hear me? Sorry.
We can hear you.
You can hear me? Okay. All right. So with increasing numbers and prevalence, there is naturally a proportional increase in financial burden on the US healthcare system. And as you can see with the figure, that's kind of roughly estimating about $6 billion, sorry, not 23, but $6 billion annually. Can we move to the next slide, please? So when it comes to the relationship between aging and the genesis of, or the propagation of atrial fibrillation, there are a few key concepts that we do need to understand in regard to the pathophysiology. So the development of AFib typically requires two major components, which are the initiation of a trigger and the formation of an anatomical or electrical substrate. The former, that out of which I mentioned, actually plays a much more crucial role in the pathogenesis of what we call paroxysmal atrial fibrillation, as opposed to the latter playing more of an important role in the persistent or long-standing persistent atrial fibrillation. And what I basically mean by this is that one of the main triggers of atrial fibrillation is from the pulmonary vein sleeves, which actually engulfed a little bit of the proximal portion of the left atrium. So many times when these trigger points are targeted, such as in pulmonary vein isolation and ablation, we actually see a complete resolution of the disease process. But most of the time when it comes to the sustenance of these triggers, it happens mainly due to the structural changes and the electrical remodeling, causing formation of new re-entry circuits and reducing the atrial refractory period. Now, when it comes to structural changes, it's things like left atrial enlargement, which typically occur due to valvular diseases like mitral stenosis and or mitral regurgitation. But at a histopathological level, atrial fibrosis, which typically occurs with aging, is very huge in this propaganda or maintenance of atrial fibrillation. But it's not just aging. There's a lot of comorbidities that actually adds to the complexity of this process of this atrial fibrosis. The comorbidities such as diabetes, hypertension, various different cardiomyopathies. These all play a very big role in abetting this process. And even in sometimes in younger individuals as well, you'll sometimes see that atrial tissue fibrosis actually happens even prior to the age of 55 or 65. And typically this actually happens when you have patients who are sometimes alcoholics. You'll see that type of situation occurring where that actually plays a bigger role in fibrosis. So in these type of situations, even with successful cardioversions, there are high chances that patients can revert back into atrial fibrillation. So moving on, with the other risk factors for AFib, as I already discussed, these various risk factors actually play a very crucial role in not only formation of trigger points, but also in structural and electrical remodeling of the atrial tissue. Now, out of all of these risk factors, cardiothoracic surgery is one of the most common risk factors that's actually directly associated with the development of atrial fibrillation. And that's actually mainly because through surgery, we're directly manipulating the tissue. We're actually causing injury to the tissue and causing fibrosis. And as I already mentioned, fibrosis is a very, very huge propaganda for maintenance or sustenance of this atrial fibrillation. Another really big risk factor that's actually mentioned here as well is sleep apnea, which is, like I always like to mention, this as a modifiable risk factor, and it needs to be it's one of the first things that needs to be evaluated after diagnosis of atrial fibrillation in patients, because controlling the issue a lot of the times has controlled the propagation of atrial fibrillation. Apart from all of these, in elderly populations, chronic subclinical inflammation, which is what is actually defined as continuous low-grade activation of the systemic immune response, is actually a hallmark of biological aging across multiple organ systems. And as a result, it actually plays a very, very big role in the development of atrial fibrillation. Can we move to the next slide, please? So when it comes to the management of atrial fibrillation, we can view it by identifying actually 4 major pillars, and they typically constitute lifestyle modification, oral anticoagulation, rate control, and rhythm control. Out of all of these, the latter 3 are actually of more particular importance in this patient population that we're discussing about today, specifically about the geriatric patients, who reside in long-term care facilities. One of the biggest challenges that we as physicians encounter in these type of situations is how their socioeconomic, can we click the next button, please? Yeah, and then the next again. Yeah, thank you, sorry. Basically what I'm saying in these type of situations is how their socioeconomic and functional status, along with their morbidity and polypharmacy, play a huge role in limiting the management of atrial fibrillation. Can we move to the next one, please? A lot of the times, geriatric patients with various comorbidities, such as history of GI bleed or AVM, limit their use of medications like oral anticoagulations, or sometimes with patients who have a history of hypothyroidism, for example, they limit the utility of antiarrhythmics like amiodarone. Even certain drug-to-drug interactions, such as, let's say, for example, someone who's taking donepezil, which already has a tendency to cause bradycardia, and you're introducing a rate-limiting medication, that itself has now a higher tendency, a higher risk of actually causing sinus bradycardia or causing falls in these type of individuals. Apart from that, frailty, as you can see, is already another important factor which is unique to this patient population. We're going to discuss more about that as we move forward. It's a question that we commonly find ourselves asking is, do certain management modalities pose more of a risk versus benefit in these type of patient populations? Can we move to the next point, please? It's typically in these type of situations, we use our clinical acumen guided by evidence-based literature to help make these decisions. But also, this is where informed decision-making also does play a very crucial role in these type of situations as well. So a lot of the times discussing risks and benefits of various managements, especially on a case-to-case basis, would typically help patients and families gain more insight into their disease process and what they would believe would be beneficial for themselves or for their family member. So that's actually all from my end. Moving forward, I'll let Dr. Reyes take it from here. Thank you again for this opportunity.
Thank
you.
Really
Appreciate it.
Thank you, Shannu. So, Sean, I'm going to take over, okay?
Yes, sir.
So, let's see. Okay, so you see if I have control.
You should be able to just click and share your screen.
Let's see. So, okay. Okay. So, so can you see my presentation? Yes. Okay. Okay, so, well, again, thank you very much. So, well, I'm going to start with a case, and this is an 81-year-old female living in your assisted living facility. She was found by the CNA in the morning, lying in bed, disoriented. She has a past medical history of hypertension, diabetes, and obesity, and she was transferred via ambulance to your local hospital. Physical exam when she made it to the hospital was an elevated high blood pressure with irregular heartbeats, 150 heart rate. She had a right hemiparesis and she has slurred speech as well as aphasia. Her EKG shows atrial fibrillation. She didn't have a prior history of that. She was found not to be a candidate for TPA or thrombectomy. She was evaluated by the neurologist after, and the workup was negative for other causes of stroke except for the AFib that was still present in telemetry throughout the admission. The patient was discharged to a post-acute facility, to actually the nursing home that is attached to your ALF. She was started on oral anticoagulation, and she suffered a fall 4 months after, which resulted in intracranial hemorrhage, and she died in the hospital. The question for the group now is, do you think that this was avoidable? So now having, okay. I'm sorry, guys, I'm having difficulty here. Sean, I think it's better if you take over. My computer got possessed.
Okay, just 1 second.
I'm sorry. Okay, so could you go to where it says speak avoidable? So it depends, yes. So, and the issue is avoidable depending on on the aspect of the case that you're looking at. Okay, it depends on if this is, I mean, if this is a patient that was a good candidate for anticoagulation, and maybe, you know, we shouldn't start them on anticoagulation despite the fact that they had atrial fibrillation and they had and you had a recent stroke, or with the fact that maybe by identifying atrial fibrillation sooner, we could avoid you know, the stroke by, you know, by preventing it by treating the disease itself. Okay, Sean, can I do the next one, please? And you know, when you look at atrial fibrillation and stroke mortality, it is clear that, and the literature has been very clear about this, that the survival actually suffers by, you know, the onset of stroke in patients with atrial fibrillation. Actually, the stroke is considered the most catastrophic, you know, complication of atrial fibrillation, despite obviously, you know, besides obviously when it develops to, you know, hemodynamic instability from RVR or for poorly rate control. But obviously, you know, stroke being the most feared complication of atrial fibrillation. Next. And then when you talk about, when Shannu was talking about benefits of treatment, next, we're talking about that there is not only, if you look in the literature, there is not only a thromboprophylaxis benefit of anticoagulation, there is also mortality benefits. And actually, when I teach my medical students and I teach their medical residents, there are plenty of studies in the literature. The one that I quote the most was one done by the Dutch on patients above the age of 90, where actually these patients were started on anticoagulation, and not only they had less strokes, but also they lived longer. Next one. So, and the most impressive thing is that the benefits of Coumadin or warfarin is actually age independent, and few studies actually have proven that even for as patients get older, the actual benefit, it seems to be, the net benefit seems to be even higher in terms of thromboprophylaxis prevention. Next one. Again. So, I mean, the first thing we need to have clear is that every recognition and treatment of atrial fibrillation is vital to improve outcomes. Why? Next one. Because there's greater incidence of cardioembolic stroke, especially in the patient population that we manage. It is very clear that frailty has been linked to significant worse outcomes, not only if you have a stroke, but also, next one, with actual functional decline. Next one. Because atrial fibrillation is independently associated with lower usual gait speed. Next one. And even patients that have atrial fibrillation, although not in the same age group that are usually managed in our homes, is twice as likely than patients not having atrial fibrillation. Next one. There is a documented increase of dementia among patients with atrial fibrillation as well, and this independent of the fact that they develop a stroke or not. Next one. And so if you say, well, if there are so many benefits, why we're not screening for atrial fibrillation? When you look at the literature, and I'm just quoting here the SAVE study, which, you know, published around 2015, looking at the actual value and cost effectiveness of routine screening for atrial fibrillation, what they found is that the reality is that regardless of how many people you screen, the threshold where there is definitely not. Next, could you hit again? And then that utilizing continuous or using screening actually is not a cost-effective intervention. Okay, next one. And if we decide to screen for atrial fibrillation, I mean, we have, as practitioners, especially in the settings that we practice, the fear of anticoagulation. And although there are tools nowadays that help us, doing informed consent, and the one that I use mostly is this one that you see is the Spark tool. You can find it online for free. And what it is a combination of the chat VAS2 and the HasWet, and it gives these nice graphics that you can see on the right side of your screen. And could you next? And what you can see is that, for example, when I'm deciding or I'm talking to a patient about the anticoagulation, we actually can see on the bars in blue the actual reduction. What is the actual risk of having a stroke when you get treated, and what is the actual risk of bleeding, which is the red bar. Now, if you see it in a crude mood here, and if you see, well, if in a medication like rivaroxaban, look at the risk of bleeding on a patient just like the patient that we had in our case. So the actual risk of bleeding is around 6%, and the risk of a stroke is 4%. So you can, it's difficult sometimes to set these numbers. Next. But when you really see what happens where your actual risk is with no therapy, you still see a potential risk reduction of around 6%. Okay, next one. And the problem also that you see with these scores is that frailty itself is not considering any of these scores, which could be, again, possible. I mean, based on our common practice, could be a high risk, or could be a risk factor for for bleeding when you start anticoagulation on these patients. Next. So again, why screen or not screen for atrial fibrillation on our patient population? And the first article I want to bring to today's journal club is one that was published in the Annals of Internal Medicine. It was published in November of last year. And the study actually included more than 500,000 Medicare beneficiaries that were taking anticoagulation, either warfarin or the 3 major neuroanticoagulants that are right now in the market. And what they found, and what they did is the propensity match group. I mean, it was a retrospective study. And what they found is that, if you looked at that common fear that we have, that these newer medications are higher risk of bleeding, or the net benefit of using these newer medications is less than with warfarin. What you look in the study that was published is that at least were the 2 major players in the market, that is rivaroxaban and apixaban, both are at least as good in terms of the net benefit. But if you look in the frail population, okay, and this is the 2 graphs that I have here, apixaban tend to have a better net benefit. So now these newer evidence and real world data on patients that are actually out in the street taking these medications, you can see that there is an acceptable risk when you compare of bleeding when you compare with the use of warfarin. And in the case of apixaban, there might be even a better safety and benefit profile. Next one. So if we have, now that we established that there are therapeutic options, and again, I'm not saying that we're going to start everybody on anticoagulation. The next study that I want to bring, or the next publication I want to bring to your attention, was the United States Prevention Service Task Force. Recently, actually, just a few weeks ago, came up with recommendations about screening for atrial fibrillation. Okay, next. And what they did is they published these recommendations to be aimed at patients that are above the age of 50. Okay, that don't have the diagnosis or symptoms of atrial fibrillation. Again, these are mostly for asymptomatic patients. And there are a couple of things that I found curious. For them, the standard of care for trigger screening is post-palpation. I found that fascinating. And one of the things that I miss, and I have not seen my medical students, I have not seen the CNAs on the nursing home, and even myself, I'm guilty of it, is actually checking somebody's pulse. So maybe now we have a good reason to start doing it again. Yeah, okay. So I want to bring to your attention the main three trials that they use to base this recommendation on: the screen AFib, the stroke stop, and the rehearsed atrial fibrillation. All three trials next had different intensities of screening. Okay, one of them actually was focusing a lot in one screening strategies, and the other ones had intermittent and continuous screening strategies. Okay, so the most important point I want to make here is that they included in their recommendations different types of screenings in terms of intensity, in terms of duration. And the issue is, we know in the literature that continuous screening for arrhythmias actually tends to yield, better, more sensitive results. So next one. So what they found is that they don't have sufficient evidence to recommend or go against screening, okay? But also they acknowledge that there are emerging technologies that have been proposed for screening for atrial fibrillation. So those are the two main messages that I got from them, okay? So next. Now, what I want to bring to your attention in terms of the two specific points of the recommendations is they acknowledge there is adequate evidence that intermittent and continuous screening with previously undiagnosed atrial fibrillation could be more effective than usual care. So I could infer from this that if we will focus more on obtaining data or designing studies that use more continuous screening, we might find a different result that it can that I can keep over the type of recommendation that they will give. And also the fact that that they specifically mention paroxysmal atrial fibrillation, okay, which is the one that you will tend to miss the most if you're not using continuous monitoring. Next. So the point I'm going to make is that nowadays we may have new technology that allows to perform continuous monitoring, okay, and that in the patient population that we serve, as Shannu accurately said, the changes that occurred with age are mostly the ones that are going to trigger the more continuous type of atrial fibrillation more than the paroxysmal type. Okay, so I want to make those 2 points clear. A, that these recommendations have some weight on not only on persistent atrial fibrillation, but also in the utility of continuous screening for paroxysmal atrial fibrillation, but also the fact that also focus a lot on the fact that their recommendations include screening for paroxysmal AFib. Next one. So again, where is the case to screen or not screen? Next. Well, if you think about it, the rationale for screening asymptomatic people is to initiate oral anticoagulant medications early enough to prevent thromboembolic events, okay? Also to prevent the development of further arrhythmias or uncontrolled atrial fibrillation. Next. And again, AFib, as Shannu described, is very prevalent in the population that we serve. Next. In addition to that, up to 20% of the patients who had a stroke with atrial fibrillation, the first sign that they will have of having the disease is that actual stroke, just like the case that we presented at the beginning. Next. And that in addition to obviously the stroke risk, so the these patients, obviously the condition or the lack or the decondition that would occur from a stroke in frail patients obviously is going to be more devastating. But in addition to that, the actual presence of atrial fibrillation without suffering a stroke also affects function. Next one. So again, if atrial fibrillation is found, in my opinion, we have the tools and the clinical skills to assess benefits and risks of treatment, and we should not deprive ourselves from tools that can help us identify atrial fibrillation early enough. Next. Next. So if we decide to screen, I think that based on, and I will touch bases on the type of technologies and the couple of studies that I found that I wanted to include in today's journal club, I think we should focus on continuous screening. Next. Continuous screening that is sensitive and specific. Okay, we don't want to increase the risk of excess resource utilization. Next. That requires little or no dexterity from the patient. I mean, we want our patients, our frail patients, the patients that we serve in our facilities, to have kind of like a passive role on the process of screening. Next, that target the highest risk patients, and I guess Shannu said at the beginning, we can identify those patients because besides age, there are also other risk factors that can place patients at a higher risk than the average counterparts of their age. Next, and we should not target populations that will not benefit from finding atrial fibrillation or from treating atrial fibrillation due to life expectancy or potential complications from treatment. Next. So, and we also, again, talking a little bit about, avoiding excess utilization, we need to actually have treatment algorithms. So whenever these continuous monitoring finds atrial fibrillation, what do we need to do that is not just sending the patient straight to the hospital? Next. So smartphones are a potential tool that could be used. There is a study actually that was published on the Annals of Family Medicine in 2019, where a group of patients used a group of scientists were trying to validate the use of smartphones to detect atrial fibrillation. Next, and what they did is they got 240 patients from different clinical practices in the outpatient setting. Next, and what they did is the patients held an actual iPhone while they were they were connected to an EKG machine. Okay, so imagine this: I have atrial fibrillation. I have known history of atrial fibrillation. Okay, I know and I hold this device that identifies that I have atrial fibrillation or not. At the same time, I'm hooked to a 12 lead EKG that is recording my cardiac rhythm. Next, and then what they found is that with the algorithms that were embedded on that device, the sensitivity and specificity for the machine for the phone to identify atrial fibrillation was 87% and 98% actually. In next. And when they see the one lead EKG that was produced in the machine, and this was and it was interpreted that one lead EKG, actually the sensitivity improved to 90%. Okay. Next. So the only issue is, the conclusions I have from this study is that technology might work. Okay. But the only limitations that in terms of screening is that this is not a screening study. This is more how I can use a machine to identify a rhythm that I know, that is known to me. Okay. And also it requires some dexterity. You need to have a patient that is holding a phone in a specific way to capture a rhythm. Okay. Next slide. Next. So wearable devices. There are several devices now in the market that have been cleared by the FDA. Next, in addition to that, such devices are reasonably sensitive and specific. Next. And the FDA actually is actually reducing the amount of burden for the approval process to have more of these devices in the market because they recognize the value of them. Next. And the most important thing perhaps is that the use of these devices when in the approval process, the FDA has mentioned specifically that the use of these devices have to be under the premises that there are going to be some interference from the primary research. We're going to have, in our case, in the patients in our nursing homes, we know we're going to run out of battery, and they're not going to charge they're not going to charge the device. We know they're going to pull it. They don't know what it is. So there are certain limitations of using this technology in our patient population. Next, and lastly, think about the difference between having an implantable monitor to detect atrial fibrillation versus actually wearing a watch. Next. So, the last study that I want to bring to you in today's journal club is one that was published in JAMA. This was published in December of this year. Last year, I'm sorry. And what they did is they group a group of patients and did propensity matching, follow patients for approximately 90 days. And then you will see that there was not an actual 90-day follow-up period. It was mostly 82 days, the actual average. And they include only patients with atrial fibrillation. So we're talking about here, what is the actual accuracy of these wearable devices? Next. And from these large patient population, only 348 of them actually were wearing devices like this one. They did a match control as a propensity matching, as I mentioned. Next. And what they found in this study is that those patients that were using the wearable devices had more healthcare utilization. Okay. Among them, including cardioversions, newer prescriptions, and visits to the emergency room. So the reason why I'm bringing this up is because these new devices seem to be very sensitive and specific in terms of, or I would say very accurate in identifying atrial fibrillation, but also come with the potential cost of having increased resource utilization that otherwise we wouldn't have. Next. So to finish, I would say, are we dead in the water? Because if you think about it, the evidence against wearable devices is applicable to the general population. But again, are we thinking about the specific patient population that we serve that has a higher prevalence of atrial fibrillation, that are more sensitive not only to the awful complication or devastating complications of a stroke, but also the simple fact of having atrial fibrillation affects their function and cognition even more. So if although again, we are not, the reason why I'm bringing all these studies is because I don't want us to think that these wearable devices are good to monitor AFib burden, is meaning the amount of time that people stay on atrial fibrillation. I think that the role of these devices is to screen for atrial fibrillation and many other things. And as Dr. Auslander said once, myself being so passionate about trying to identify sepsis in nursing homes early enough, before, as Dr. Joe says, before I'm on the wrong side of the grass. I think that these wearable devices have a role on treating and taking care of our patient, or the patients that we serve. Because I truly believe that early diagnosis of newly developed atrial fibrillation can avoid a functional decline, physical and cognitive. That early diagnosis of atrial fibrillation or newly onset atrial fibrillation can avoid catastrophic outcomes such as stroke. Because if the first sign of atrial fibrillation is a stroke, it was already too late for us, like for that patient that we presented at the beginning. that the pros and cons of oral anticoagulation now with the new scoring systems and the new emerging evidence, I mean, I think that can be discussed. And I think that we have to start moving away from the fact that anticoagulation is the evil, that might be safer than what we think. And definitely that, you know, again, these newer evidence that is emerging, specifically that study that I showed on that retrospective real world experience on Medicare beneficiaries, things that medications like apixaban could increase the level of comfort that we have using anticoagulation. Next. So the lady that we had at the beginning, okay, what would have happened? I think that what was going to happen in the future is, next, that instead of having this sad story, next, we will see that when she comes to your office in the ALF, you advise her about her risk of developing atrial fibrillation because of her history of hypertension, obesity, and diabetes. And she decided to start using an electronic watch that can detect and explain her abnormal heartbeats and her sleep quality, and even notifies her if she falls. And after using the device, she gets an alert that says that she had an irregular heartbeat. And what happens is that technology now is so good because these things now get connected to the internet, even without having a cell phone close by, sends that alert immediately to your to her primary care physician, who does not freak out because knows what to do, because there are treatment, there are specific treatment algorithms that are already in place. He calls the home health agency, gets an EKG, okay? The EKG actually confirms that the patient is an atrial fibrillation. And you follow up with her in the clinic right away, that same day. You start her on oral anticoagulation and you refer her to cardiology. And I think that this is going to be the future. I think that we should steer away from, you know, not using anticoagulation, especially with the new data. And I think we should start opening our eyes to this new technology that would allow us to take care of our patients without having the burden of in our practices. Okay, next. And again, what I always say is, as the largest chapter of AMDA, FANDA should be, you know, the society that drives changes on standards of care in the patient population that we serve, that is patient-centered and evidence-based. With that in mind, I am done, and I will open it for discussion. Thank you very, very much. And again, I apologize, that was a little bit choppy, but it's very difficult to, you know, keep talking or saying next and next.
Thank you, Dr. Reyes. Thank you, Shannu. If anyone has any questions for either of our speakers, please take yourself off mute, or you can enter it into the chat. I just want to say I thank you both for a very thought-provoking presentation. And I am very curious to know what you think about possibly doing a study with wearables in the nursing facilities. I haven't seen one as of yet, but I know I've read a couple of white papers and research papers on looking at the 65 and older population and wearables and what we're finding with some of that data that's coming out. I'm just curious. That's to you, Dr. Reyes. Yeah.
Okay. So there are currently there are Apple. Actually, I'm sorry. I'm just saying Apple because I have no stocks in Apple of any kind, and I have no financial interest on. But Apple actually now has partnered with I think it's the Institute of Aging, and they're trying to actually fund research based on the wearables. I'm not aware of any ongoing, major trial. And actually, I checked on clinicaltrials.gov as yesterday, and I couldn't find anything. By the way, I mean, if you're going to, just to let you know, if you want to try to get one of these wearable devices to be used for a specific condition, you need to submit a NDA anyway. Okay, so which is a new NDA, a new device application to the FDA. So as yesterday, there was nothing in clinicaltrials.gov that is registered. I don't know if somebody else has other information. But Dr. Sanders, so going back to like, you know, following up with the second part of my answer, I think that there are two things you need to consider. First is the utility of constant monitoring. Okay, as you know, using fixed parameters in our patient population to determine, so having thresholds, so when we should, you know, consider sepsis or when we should consider, you know, hypertension in our patient population, those fixed parameters do not work really well. I mean, variance from what is normal to each one of our patients seems to be a more realistic approach to determine when there is a serious illness. And I'm talking about, for example, somebody that we have with a systolic blood pressure, for example, of 150 in our facility. If they drop their blood pressure to 110 or 105, they wouldn't meet criteria for, you know, for hypertension and wouldn't be concerned about sepsis. Okay, but the reality is they had a drop in blood pressure of more than 30%. So I'm going to use that as an example that I would use variance. What these devices are going to help us to do is to determine variance on what is accepted for a specific individual, and determine and possibly identify acute illness early enough to avoid complications. And we will steer away from using fixed parameters that definitely are not sensitive or specific enough for the patient population that we serve. I think that that's one of the major achievements that this technology can have in the near future. On the other hand comes the issue of privacy, you know, how much our residents wants to be monitored all the time. And the actual, and then the second problem is also, you know, resource utilization. Are we designing algorithms that are specific enough so every time there is an alert, that alert does not trigger unnecessary testing and treatment? So those are the two major concerns I have. But I think the net benefit of using these devices in our settings is there is a lot of potential.
Thank you. Any other questions or comments?
Hi, this is
Dr. Reyes.
Simone.
Oh, sorry. Go ahead. Sorry about that.
Should I go ahead?
Yeah, go ahead. Go ahead.
Hi, it's Simone. Thank you so much for this awesome presentation. And I echo what Dr. Sanders-Cepeda said. It just unfolds a lot of things that you have to think about, and it's impactful. So my question, Dr. Reyes, is with the wearable device and the impact as far as algorithm is concerned. So how do we detect, say, for instance, a patient that has a new onset AFib? Is there a way to determine or to get more information in regards to other parameters? Are they a dialysis patient? Do they have a mechanical valve? Is there something going on that will determine what steps we take as far as a vitamin K antagonist versus a DOAC? So will there be more information in reference to attached to the wearable device?
Okay, so I think that the question you're asking is, if we identify atrial fibrillation, if we design treatment algorithms in terms of anticoagulation, should we have clear guidance of what to start if it's appropriate?
That's correct, because
Yes,
there's so many other parameters and other diagnoses and comorbidity that we have to look at before starting anticoagulation. And again, based on the CHADS-VASc score, which I did not catch the beginning of the discussion, but based on the CHADS-VASc score too, we have to take a look and analyze whether it's necessary to treat with an anticoagulant or an antiplatelet. So is there more that we have to unpack?
Definitely. I think that we should, at this point, again, what I'm proposing is try to open our minds to the use of these wearable devices in our settings. In terms of, I mean, the literature is clear, and actually, in what anticoagulant is to be used in every specific circumstances. So there should be plenty of guidance attached to the use of these devices. If we're going to use more anticoagulation, you should have more decision support systems to guide the process of deciding if somebody deserves or needs anticoagulation or not, and what type of anticoagulation. Hopefully that answers your question. We have, and I have to disclose that I'm part of the team that helps Dr. Joe maintaining and updating Interact. I mean, I think that Interact is a good example of it. I mean, Interact actually is a quality improvement process that helps you. I mean, one of the things that I like about Interact the most is it helps you with early detection. But early detection does not help that much unless you have a algorithm that helps you decide what to do if you encounter that specific circumstances. So we have experience in our settings about the use of algorithms to help for decision support.
Okay, thank you.
Any other questions or comments?
Diane, I have a question and a comment. Thank you guys both for, first of all, for great presentation. One of the key questions that I feel Bernardo is here is the risk of thromboembolic stroke with paroxysmal versus persistent atrial fibrillation. And my understanding in the article, it says that the risk is uncertain. I don't know how it compares to persistent. Historically, somewhere along the line, I have no literature to quote this, I used to almost have the feeling, or have heard from cardiology, whatever, that there might even be an increased risk for an event with paroxysmal atrial fib versus persistent. But I don't know if that's true, and I'm not aware of literature to support that. If indeed there is a higher risk, that certainly would drive even further the use of measurable devices, wearables, et cetera. And it would increase the value of being able to detect what they call subclinical atrial fibrillation. Thanks.
I mean, the first part of the question is if paroxysmal atrial fibrillation confers the same risk as persistent atrial fibrillation, right?
Right.
Okay. I'm not sure if Shannu wants to take this one, or you don't mind if I take it, Shannu?
Yeah, no, go ahead, Dr. Reyes. I'll try to jump in if I can think of anything.
The literature shows, that's an interesting question, Dr. Carlin. So the literature shows that the risk is exactly the same. I mean, the burden of atrial fibrillation is not directly correlated to the actual risk. The time that you develop the symptoms and if you think about it, the CHAS-VAS score does not tell you if you have paroxysmal or not, right? Once you identify atrial fibrillation, you're at the same risk, and your CHAS-VAS score, what it does is it guides you about the type of anticoagulation or if you need anticoagulation or antiplatelet therapy. The current literature suggests that if you have paroxysmal atrial fibrillation, you're at equally the risk of having a stroke that if you have persistence. Now, the second part of your question is these wearable devices will increase the diagnosis of paroxysmal AFib, right?
Right.
Yes, it's
right.
Definitely. Now, I'm going to say something very interesting here. What Shannu said at the beginning is that some of the reasons why people have paroxysmal atrial fibrillation are reversible. So think about somebody that is at risk of having a stroke. You identify paroxysmal atrial fibrillation, and then you're asking common questions like, do you have sleep apnea? Okay, that is not being treated. So maybe you can even treat the paroxysmal atrial fibrillation with a CPAP machine. You're avoiding a stroke by just providing a CPAP to somebody. So I think that's where the other piece of relevant benefit is here, and is not only is early identification and also identification of paroxysmal atrial fibrillation that commonly goes unnoticed until somebody just get a stroke.
Okay,
Yeah, and Dr. Reyes, to kind of add on to that, I mean, from what I know about the Rocket AF trial, I believe that their initial aim was also to kind of evaluate if there were any, what the rates of thromboembolic strokes were between patients with paroxysmal versus persistent. And I think theoretically they were suggesting that, patients in persistent atrial fibrillation are in a longer state of that irregular rhythm or that state of standstill, which actually predisposes the patients to form more thromboembolic formation within the atrial appendage. As far as I believe, I think in the Rocket AF, they did mention that persistent had a slightly higher risk of thromboembolic phenomena, thromboembolic strokes, especially in patients with high risk features, for patients who had a CHA2DS2-VASc of more than 4. Specifically is what they actually were able to find in further subgroup analyses, I believe is what they had found in that.
Well, you see.
Well, I'm sorry, Dr. Reyes. I was going to say we're way over time.
Okay.
Please finish your comment though, because I definitely, this is all very good and interesting.
No, the comment I was going to make is that the patient population included in the Rocket trial, I don't know what it was how many of those actually are, because the current recommendations from the American Heart Association guidelines, they don't make clear that differentiation. But obviously, again, my advice to people is that if you identify paroxysmal atrial fibrillation, you should be considered the actual risk of stroke, and it's calculated by the CHA2DS2-VASc score and then start anticoagulation. But I obviously, Shannu, thank you very much for the comment. It's very valid.
And Bernardo,
thank you.
I just want to thank you both. Dr. Reyes is saying maybe we need a part 2. I think we might need a part 2 and a deep dive into thinking about how we're utilizing wearables, algorithms, and I didn't even get to ask all my questions about AI and thinking about where we go from there. So I may have to hit both of you up in the upcoming weeks. So I thank you both.
I totally agree. Yeah.
This will be recorded so you guys can listen to it, and the handouts will be made available to you. Thank you all for joining.